So thank you for the invitation to be with you this morning. I've hardly ever been introduced as pious. My family will enjoy that immensely.
I should have said he looks pious. He looks pious when he sings in the choir at Grace Oak Park.
That's true. That's my most artistic moment. I do worship at the other Grace, as we refer to it, in Oak Park with my family, where I sing in the choir. I'm a tenor because, you know, wow. That's the only way I get to sing is they're always hard up for tenors. During my pesky day job, though, I work at Rush University Medical Center as a lawyer, priest, and bioethicist. You know, one of those. My kids have no idea what to say at career day. He's a lawyer, but he doesn't practice law. But he works at the hospital, but he's not a doctor, and not the kind who helps people. You know. So what I do get to do is all and everything I know how to do in one place at one time every day when I go to work. And it's a great gig if you can get it. My work there involves leading both spiritual care and ethical reflection on healthcare. So we're the medical humanities department in the university where we teach medical students and students who are studying for ministry. I teach nursing and allied health professions, healthcare ethics across an interprofessional span. And my scholarly interests are in end-of-life and palliative care. And hence the focus today on these issues. So what I want to think about with you a little bit is at the intersection of the parts of our lives that include healthcare, managing maybe our own healthcare or that of others who we love in our family, and our faith life in these walls. And I don't know about you, but we often don't get to talk about it. Right? We don't think about how those parts of our lives touch each other until we get hit in the face with a situation that causes us to have to think about it. Helen Keller knew something about when life confronts you with a challenge, and she said that life is full of suffering, but it's also full of overcoming suffering. And as you know her story, she certainly knew something about overcoming it. So I want to think with you today a little bit about how we think about suffering. How do we consider what suffering means? You may have been around for the past few weeks at church. Anybody remember what that week before Easter is about, right? We talk about the passion of Jesus, and passio, the Latin word is literally suffering. We enter into the suffering of Jesus as he enters into our lives, into our passion, our passio. So I want to think about that with you in a place where we can really think about it, right? I want to think about end-of-life and palliative goals of care, as well as curative goals of care, right? That we have in healthcare. I want to think about the spiritual needs that we have throughout our lives, and to think about the fullness of our biomedical, psychological, social, and spiritual well-being when we're healthy and when we're sick, in our living and in our dying. And so I begin with this premise that is part and parcel of our Christian heritage, but difficult to articulate in the context of modern American biomedical science. And that is to think of yourself, right, as certainly embodied. We know that as Anglican Christians, right? What is it that Teilhard de Chardin says? We're not physical persons having a spiritual experience. We're spiritual beings having a physical experience. This embodied spirit is part of our understanding of who we are as human persons. But if you go to the hospital, what do they do there? One of my critical care friends says, we're like an auto shop. You bring the car in and it's broken. We get under the hood and fix what's broken. We get you back out on the road. That's it. He says it's very mechanistic in that way, and that's this notion of the biomedical model. It thinks about diseases, right, that are cured, treated, cured, right? Illnesses that can be fixed, right? Broken bones that can be set, tumors that can be taken out surgically, right? They're things that we can do biomedically that are fantastic. And by the way, just so there's no, don't get me wrong, if you see me at the side of the highway on the way home today in an accident, please fix what's broken, you know? There are tremendous, tremendous advances that are keeping us alive and healthy longer than we ever have been before in human history. And that's to be celebrated. It's also to be noticed that we're more than our bodies. We're more than the gallbladder in bed 3C, you know, in the hospital ward. We are people with rich emotional and thought lives who are embedded in social relationships, in families, in communities, in cultural contexts, in church communities, maybe, right? Networks of mutuality, Martin Luther King called them. And we're spiritual beings. We have this domain of our experience where we make sense of everything else, right? Without that place where we can think about the meaning and purpose and value of our lives, the rest of our experience may not make a lot of sense. And you know that because you're here. Right? It's what we do in communities of faith, whether they're Episcopalian or anything else. We engage each other in this conversation around our inspirited lives. You know about this. This is still, after 30, 40 years, still a sort of challenging concept for physicians and nurses and other healthcare providers to think about, because they know a lot about how to treat the body. The rest of the psychosocial and spiritual domain are a little scarier, because it's not quite so clear. And that's where we work together in these interprofessional teams. So you notice we have specialists for each of those domains, right? We have surgeons and physicians, nurses to treat the biomedical needs we have. We have psychologists and we have social workers. We have part of the challenge is for us to work together as teams to provide care for the whole human person. So it's whole human person care all the way through our lives. And so if you have ever talked about palliative care, end-of-life care, you know that we want to pay attention to pain and symptom management just like we do all the rest of your life. And we want to think about the psychological support that people need, right? And we want to think about what kind of social support you need, because what's the first thing that happens when somebody gets sick? They get socially isolated. Right? There's a whole research literature. We can document the ways in which illness, and particularly chronic illness, interestingly enough, leads to social isolation, because who wants to go visit after a while? Right? I don't know what to say, people will tell me, if I go to visit so-and-so in the hospital. What will I tell her? Right? So one of the things that happens is we visit less and less, and we tend to socially isolate the people who are sick in the society. It's one of the things we can work to overcome through things like pastoral care. Somebody told me that they'd done training in Bishop Anderson House's lay pastoral care training program. Precisely, Stephen's ministry. Do you have a Stephen's ministry here? It's precisely to overcome some of the social isolation and the need for spiritual support. Right? For someone to be there for you. And we'll talk about what those look like a little bit more. But part of this is precipitated by the understanding that with all of the remarkable advances in American healthcare, there are still only a few things we can cure, if you think about it. What most of the advances, beyond some straightforward surgical interventions and a few infectious diseases, right? Beyond those, once you get done with those, much of what modern medicine does is manage chronic illness, right? In fact, it allows us to survive long enough to have chronic illnesses. This is one of my colleagues is the director of our Alzheimer's research institute, and he was giving a talk not long ago in which he explained that on autopsy, which is the only way you can really diagnose Alzheimer's disease definitively, something like 90% of us, if we live long enough, will die with these plaques in our brains, which is kind of scary. But the point is, we're living long enough. But that's what's changing, is that we're living long enough to have these chronic illnesses develop. And so that's one of the changes here. And in a way, another way of thinking about that is that our living and our dying are both prolonged in that scenario, right? And so we have to think about it differently. If you ask people, and I'm sure if we took a vote in here, how they want to die, they'll tell you, I want to die at home, yeah, comfortably, right, quickly, right, just in my sleep. I want to be in control. I want to be able to communicate with the people who are important to me, right? I want to be self-reliant. I want to have my family around me, and I want to be in right relationship. We say righteous with God. Right? That's what we hope for. This is a picture of the Olduvai Gorge. Anybody know this? So the idea is there's a chasm between what we want and what we get. Right? Most of us will die in the hospital, right? With some degree of unmanaged pain, most likely over a prolonged period of time, with a sense of loss of control, not communicating well, but actually fearfully, dependent on technology, surrounded by staff, and ultimately depending not on God, but on physicians. There's a marvelous literature. A colleague of mine once wrote a significant paper 20, 30 years ago called The Physician as Priest. And he chronicles the development in Western civilization of the transfer of power in the society. Yes, I'm looking at you. We were having this conversation earlier. This transfer of power in Western society from the power of the priestly office to the power of the physician, right? As a sort of locus of social authority. So there's a big gap. How do we close it? Well, we think about how all of us can be engaged in, and this is an interesting issue in a theological context, take control of our healthcare lives to the extent there's control to be had. And this is actually an interesting conversation that we can have. I think a lot of the suffering that I encounter in the healthcare context has to do with wanting to control things we ultimately can't control. I checked on the way in this morning. The death rate's the same as it was yesterday. 1 for 1, right? There are some things we can't control. Our mortality is one of them. The fact that we are creature rather than creator in our Christian context. But we can talk about these issues. We can help people to get what they want. That is to say, the kind of care you want to have at the time you want to have it, when you might not be in a position to speak up for yourself. It's called advanced care planning. It's something I thought we might talk about next week, actually, in some detail, and actually work through some advanced care planning documents. How many of you have a durable power of attorney for health care? Oh, see, you're the choir. So we can talk more about that. It's a lot of the work that I do. And this is, of course, not just about end-of-life care. It's about all the way across a continuum of care. So again, if you know about advanced care planning, you know that it's a way of documenting, right? The advanced directive is merely the memorializing of a conversation. That's for the lawyers in the room, right? For those of you who might be clinicians, it's like a chart note, right? The chart note documents that you did something, right? The advanced directive documents that you had a conversation about who you want to have make decisions for you when you can't. Who would you trust to speak for you? That's the person who's the surrogate under a durable power of attorney for healthcare, or the kinds of treatment that you want or you don't want. It turns out that this is a critically valuable thing, not just for your healthcare providers, but for people who might need to be making decisions on our behalf at a time when we can't speak for ourselves, so they know what we would want, right? So they can speak as if they were the patient, instead of guessing. And everybody suffers from guessing. I don't know what she'd want, but I can't bear to, not do everything we said, right? And it puts people in a very, very difficult position when we don't know what the person we care about would want, what kind of comfort measures they'd want. This 5 Wishes document is interesting because it includes sort of imaginatively projecting yourself into this situation that most of us are unfamiliar with, about what kinds of comfort care are they? Cool cloth if I'm feverish. Yeah, that actually sounds good. If my lips are cracked, a glycerin swab, that's a good idea, right? Clinicians know this, nurses and doctors know about it, but most of us don't. And so this gives people some insight into how to do that. And this last question in the 5 Wishes paradigm, what I want my loved ones to know, sometimes called an ethical will. It's a way of communicating kind of life lessons and forgiving your lousy, no good brother-in-law for that fight you had 30 years ago, that you've never quite gotten over. That sort of thing. It's a great conversation piece. I tell my students, this is the thing you want to take home with you at Thanksgiving break and leave on the dining room table, and see what kind of conversation it starts, right? In making these kinds of healthcare decisions, we teach students, and we think about, we try to think about some principles of ethics that can apply to healthcare. Principles like respecting the autonomy of people to make their own decisions. Who do you want to have make your healthcare decisions for you? You do. Yeah? Right now. I mean right now. Yeah?
Me.
You?
Yes.
Yeah. Why is that?
Because we're still in
This is the ethics question, why? I'm always pressing people for why. Give me the reason, because I can, right? And because don't you deserve to? That's this notion of autonomous moral agency. In theological terms, it's because you're a child of God. You have inherent worth and value as a human person. And so that principle recognizes this. We think about the principles of do no harm, primum non nocere, the Hippocratic oath in Latin. First of all, do no harm. Don't break anything that wasn't broken when you got there. But is that all you're supposed to do, or should you actually try to help people? And so we have to balance often trying to help people with not causing them harm. And you'd think that'd be a no-brainer, wouldn't you? Right? Given the choice between harm and help, what would you choose? Well, ever pulled out the insert in a bottle of Tylenol or something and unfolded it? Right? What's it covered with? The side effects, right? Side effects, which are really, incidentally, just the effects we don't intend. Right? And so we're always, whenever we're trying to help in healthcare, modern medicine, we're always balancing, right, the good we want to do with the harm that's foreseeable, that comes along with it. How about surgery? Right? What's that involve? cutting people with knives, it's a pretty big harm. It better have a pretty darn good benefit to outweigh, right, that risk of harm. And finally, this principle of justice tells us that we should try to treat people fairly, right? Treat like cases alike, distribute healthcare equitably, and whether that's ventilators in a pandemic flu epidemic between hospitals, or healthcare dollars in health policy, right? Those are justice kinds of issues. Transplant ethics is all about how do we decide who's going to get a scarce resource like a kidney that they need for transplant. The interesting thing here is to recognize that these are sort of the lingua franca of American bioethics, but it's not the only language. Those aren't the only values that we might appeal to. We might, for example, in Christian theological ethics, think not just about the autonomy of individuals, but about our relationship to one another in a community, in families, in nurturing communities like, say the church, right? As a relational value, could that be important too? And so one of the things that we see frequently are people who want to make decisions together with their family or loved ones, together with a spiritual leader or advisor, right? Not necessarily all by themselves, right? And that's a clash between a worldview that might take some of these things seriously and a medical culture that says we've got it all nailed down and we know how to think about these decisions. So one of the things that I'm frequently engaged in is this kind of culture brokerage between the culture of medicine and everybody else's culture. Because everybody who walks through the doors of my hospital is a foreigner. It's a foreign culture. I don't care. Even if you're a healthcare provider in another institution, there are very particular local customs in each hospital, right? In each health system, in each doctor's office, right? That are culture specific. So it's an interesting way of thinking about it. You can think about is not doing harm enough, or do we actually value in the Christian life something like caritas, caring, kindness, devotion, compassion? Think about some of the alternative values you might hold. Is doing good the highest form of service, or do we actually call people who act altruistically, for example, we call them heroes? What does it mean to have compassion for someone? Is justice as fairness the goal, or might we actually need to have a preferential way of thinking about those who are actively disenfranchised or disadvantaged? The preferential option for the poor is the Roman Catholic theological term for that. So it's just to problematize a little bit, to ask her where's the locus of value for you in the healthcare decision making that you take. This is Martin Marty from the Park Ridge Center for many years up north here, now at the University of Chicago, articulated very nicely how we might do this. He says that the religious voice in these bioethical questions, right? He was writing about cloning at the time, is grounded in resources in addition to reason, intuition, memory, tradition, community, experience, hope, affection. He said that all of those are resources that thicken the conversation, addressing the reasons of the heart that reason cannot know. It's the reason I do the work I do at the interface between religion and bioethics and healthcare and medicine. It's because I think it helps us thicken the conversation. It allows us to say out loud what we might be experiencing in our hearts. Elie Wiesel says, I've learned 2 lessons in my life. He says, first, there are no sufficient literary, psychological, historical answers to human tragedy, only moral ones. And second, just as despair can come to one another only from other human beings, hope, too, can be given only to one by other human beings. So that's what we're in the business of, I think, is bringing each other hope. Turns out when we ask, most people would like their healthcare providers to address their spiritual well-being, right? To take seriously that biopsychosocial spiritual model of the human person. About 2/3 of respondents say that they would welcome inquiry by a doctor. About 15-16% pretty consistently over the years that Gallup has been studying this, and this is consistent with the Pew Center research as well, say, no, actually, you know what, that's not what I'm looking for when I go to the doc, thank you very much, or it's not important to me, right? So if the answer can be yes, it has to be able to be no. The interesting distinction is between the 2/3 who would welcome inquiry about their spiritual well-being, right? And if you ask them, has your doctor ever talked about it? Only 15% say yes. So the 50% gap between those two is the thing we're missing. Right? That's the conversation we're missing. That's what I like to show my physician colleagues, to say, it's okay. Actually, people don't mind. They kind of like to talk about it. But if we poll physicians and ask, do you? They say, no, I don't have time. I don't really know how to talk about spiritual stuff, and I wouldn't know how to identify patients who want. I don't want to project my own beliefs on other people, the fear of proselytizing. I don't think it's appropriate to my role, so on and so forth. What I like to point out is that most of these are things you can do something about. You can learn how, for example. And so there are programs around the country. The George Washington Institute for Spirituality and Health, for example. Dr. Christina Puchalski has developed a whole curriculum for training physicians very specifically in how to do spiritual assessment as part of their regular assessment of patients. Nursing is way ahead of us, way ahead of the curve on this. They've included spiritual assessment for many years in standard nursing assessment. What might that look like? Well, one of the things that I find pastorally helpful is thinking about spiritual well-being developmentally. That is to say, that we grow and we change across. Anybody teach Sunday school? Been engaged in that? Christian education ever, right? You know, the kids look different when they're little than they do when they're, say I met a teenager or two out there at breakfast, right? James Fowler was a student of Lawrence Kohlberg, a psychologist of religion, and he said, you know what? In the same way that people develop moral intuition over the course of their lives, he said, they seem to engage in faith development. So he's done some, I think, 30,000 interviews with people over the course of decades and decades at Harvard and now at Emory, where he's traced out these developmental stages. He says, our faith develops from infancy, where, what do babies believe in? Well, they sort of place their trust in whoever is
feeding them.
Yeah, right? And the sort of very basic physical needs for comfort, undifferentiated. He said early childhood children project onto whoever is present in their lives. Who's the caregiver? Who's the caretaker? They know intuitively that that's who I can trust. My 9-year-old son, if you ask him, the stories, he's learned the stories of the faith, right? These stories that we use to communicate with, that are the Sunday school stories and so on. He knows that the story of Noah's Ark is about the cute little doe-eyed animals that march 2 by 2 onto the boat, and then there's a rainbow at the end. Would it be appropriate to explain to him, why God wrought that havoc on human because of their utter depravity? Should we try to impress upon him? Right? probably would not be quite developmentally appropriate, right? Because he has this literal way of understanding the story. In adolescence, however, my 15-year-old daughter will try to synthesize a faith of her own, but the only building blocks she's got to work with are sort of what she's received, this conventional faith, the faith that's passed down to her. And so there's a moment here in adolescence where they're trying to create something new, right, by repurposing what they've got. Most of us are just not creative and brilliant enough to make up our own worldviews and philosophies and religions, right? Instead, we tend to piece things together from the building blocks we've got. In young adulthood, however, we actually go on this sort of fishing expedition, if you will. We call it spiritual seeking, right? Where we go out and check out other resources for our spiritual well-being. Anybody else go through this? How many of you are cradle Episcopalians like me? Yeah, so this is an overrepresentative group. You may or may not have gone through this period, right, where you kind of left and checked out something else and maybe made your way back, right? Did you? Okay, good. Yeah, so that's this individuative and reflective faith, because part of the task of adolescence and young adulthood is rejecting your parents, right? What do teenagers think about their parents' music, or the way they dress, or their politics, or their religion, right? It's all embarrassing. Eyes roll back in the head, right? Preachers' kids have this bad, I'll tell you, because they're individuating from us in order that they can reflect on finding what I call a faith that fits, right? Something that makes sense and helps them find meaning and purpose and value. At this point in most of our lives, what Fowler suggests that we might be experiencing is the ability to live with a conjunctive faith. And this is the faith that's able to say both and, as opposed to either or. And I think as Anglican Christians, Episcopalians are particularly good at this both and kind of faith. We can live with the paradox, with the mystery of the incarnation. We can do something with the paradox of the resurrection of Jesus Christ that we just celebrated at Easter, right? Not a straightforward either or kind of black and white event, right? It requires some living with that kind of mystery. And then he says there are very few of us who will make it in life to a point of universalizing faith. He said, and they're the usual suspects, he points to, right? Can you imagine? Can see the unity between all human beings. Who do you think he's talking about? People like, any nominees? Mother Teresa, the Dalai Lama, Martin Luther King Jr., those characters, right? Most of us, probably not, but we can aspire to it. What I find helpful about having a sort of developmental picture in my mind is that it gives us all permission to be who we are and not to be who we're not at any particular point in our lives. One of the things we see a lot, for example, in the hospital setting, is people confronted with mortality or illness, either for themselves or a family member, sometimes for the first time, right? It's what we call the N of one problem, right? Hopefully you're only going through this once in your own life, whereas the professional caregivers see this day in, day out, so they have a sense of what the population might look like. But for me, this is only happening once, and part of what's hard about that is that I may be bringing to my experience of illness, for example, the child's eye view of my faith, right? Because that was the last time I paid any attention was in confirmation class or at my bar mitzvah or whatever it was. And so we're often trying to help people kind of catch up quickly between their child's eye view of their faith, which might lead them to say, it's got nothing for me, there's nothing there. in religion or spirituality. And then we have these events throughout our lives. So part of the good news is that you've got resources, because if you've lived long enough, you've lived through some changes in your life. So if you think about your spiritual well-being, and we have instruments that can measure this. If you think about spiritual well-being at any given moment, you might put it on a continuum from something like spiritual crisis to, spiritual nirvana, or, whatever you think of kind of the greatest spiritual well-being. You kind of just take a quick snapshot in your own mind about where would you place yourself on that. Are you searching? Do you think you have kind of well-established beliefs? You know what you believe in, and you're pretty comfortable today? Are you in a period of spiritual growth right now? Sort of burst of creativity and searching? And wherever you think you are, what happens when life intervenes and you get, the new diagnosis, right? Or a couple of planes hit a skyscraper in New York, right? And what happens? People are kind of thrown back on their heels, and they ask questions like, how could God let this happen? We call it the theodicy question, right? And the number of conversations I have like that, where I'm suddenly thrown back into real confusion or distress, right, around some difficult life event that I'm coping with, the death of a loved one, the illness, the trouble of child, pick your crisis, right, through which we work together and support each other to grow, to find our way back to some new normal on the other side that we never wanted to know might exist, right? And so part of what I encounter a lot is that we're churning through life and learning coping skills, right? We're learning how to deal with crisis. We're learning how to deal with the bumps and bruises of life because we've done it before. And so often what I'm trying to help people look for is how have you gotten through stuff before? How have you gotten this far in life? It turns out that lots of us might be engaged in supporting each other in these times, including those of us who work in healthcare chaplaincy, people in the community, lay pastoral care providers, and healthcare providers, as well as family members and friends. We're all in this together. So whatever role you may have, you've got a role in supporting each other's spiritual well-being. That is this place where you find meaning and purpose and value in your life. I've always been interested in this result from Gallup that we know what people want when they're dying. When they're dying, people say they would look for spiritual support. Now, you got that? For spiritual support, they'd look to clergy. 36% say, a third of them say clergy. Right? That's reassuring, isn't it, Bob? Right? Yeah. Another third say they're doctors, and another 20% say they look to their nurses for spiritual support. Did you catch that? And so the indictment of those of us who are clergy is only a third of people say they'd look to us for spiritual support. They don't think we want to talk about it. And that's why we're here, I would suggest, so we can talk about it. There's research about specific reassurances that people find comfortable. The interesting thing to notice about the list is that God doesn't appear until the middle of it. There are lots of reassurances that people find spiritually significant along the way. We, all of us, need to find sense and meaning in our living and in our dying. People are looking to accomplish these tasks at the end of life, right? To have that sense of recognition that my life is valuable. So we do a lot of work in hospice and palliative care, for example, around storytelling. Right? Pull out the photo albums and tell the story. make that life into a narrative, a story that makes sense, right? With this last chapter. To have companionship. I was once having this conversation in a congregation, and the question time came, and one lovely woman in the back of the room said, I don't know about anybody else, but all I want is someone there to hold my hand. When the time comes, I want somebody to hold my hand. And half the room said, "Oh, I'll be there. I can do that. That I can do."
Can I ask just one very quick thing?
Absolutely.
The to die appropriately. Can you expand on that a little bit? Because it looks like it's just a combination of all the others.
That doesn't make any sense, does it? What could possibly be appropriate about dying? Yeah, and I think that's quite to the point. What it seems to reflect in this research is appropriate for me. That is, there isn't one right way to do this. And some of my friends in the hospice movement can sometimes, they'll acknowledge, we can be a little doctrinaire about this. You've got to, we expect you to march through the stages of grief just as Elizabeth Kubler-Ross laid them out in order, right? And get to the next one before you move up, right? It's easy for us to think about any of what I've been talking about as normative, as if you have to check the boxes and do it right. And so what it means to die appropriately is appropriately for the individual. And that's part of the focus of advanced care planning, is to ask that question ahead of time. What might that look like? What might be appropriate for you or for me? Because it might be different depending on who we're talking to. Does that help? Appropriate for the individual. So that's a terrific question. What does it mean to suffer? It means sometimes that that biopsychosocial experience we have gets broken apart, and we only pay attention to one part of it or another. And that's Eric Cassell's notion of the fragmentation of personhood, in his very influential paper in the Journal of the American Medical Association. Howard Brody, another physician, bioethicist, a colleague of mine, refers to the suffering as the breaking of stories. He says, and this actually speaks to your question about appropriateness, he says, what you're really asking when you go to the doctor is, "Help me, doctor, my story's broken. Help me fix my story." And what he means by that is, it's the story of my life that I used to tell that, explained who I was and what I did. I'm, young and active parent, and now you tell me I've got cancer. And I don't know what that story, how's that story go? Help me tell the next chapter of it. Right? How do we edit that new story? Ira Byock at the University of Wisconsin says that suffering is a challenge to meaning, right? The meaning making or spiritual domain. We obviously have religious perspectives on suffering. I mentioned Holy Week, didn't I? Good Friday. Can't get from Palm Sunday to Easter without going through Good Friday, right? Without going through that suffering experience. One theologian says, suffering and joy both teach us, if we let them, how to make the leap of empathy, which transports us into the soul and heart of another person. In those moments, we know other people's joys and sorrows. We care about their concerns as if they were our own. It's a lovely description of empathy, right? Of what it means to empathize with someone, to meet them where they are. So that's what we hope to do in palliative care, right? To respect people's goals and wishes, right? The choices people make, to attend to the whole of the human person, right? Biopsychosocial and spiritual needs, including family members. We'll end with this today and then open it up to questions. The idea behind this notion that we are talking about a continuum of goals of care in healthcare is that from the point of presentation with a disease or a diagnosis to the time of death, we have goals, right, for what we want our healthcare to be about. And usually they're curative. They're usually curative or remissive. Think about getting a cancer diagnosis. That's probably one of the ones we're most familiar with. If you get that biopsy result back, what's the oncologist likely to recommend? How are we going to treat that tumor? Oh, well, let's take it out, right? So we'll do some surgery with the goal of curing, right? We'll do some radiation with the goal of curing. We'll do some chemotherapy with the goal of curing the cancer, right? We talk about the disease that we're curing. Right? What happens if we get out here a few months and we have a recurrence? We might try another round of chemotherapy. And you notice there might be one more thing to try, and we wind up with people who die in the critical care, in the ICU, right? With chemotherapy still dripping in their arms because we're still trying to cure them right up to the time of their death. Somebody like Dame Cicely Saunders came along, and the founder of the modern hospice movement, and she said, well, isn't there some period at the end of our lives when we should be thinking about the whole person, right? And not just trying to cure the disease, but trying to manage the pain and symptoms, psychosocial and spiritual needs of people, right? And so the creation of hospice was to be a place for that to happen. The problem with that model is, where's that bright line between the curative and the palliative goal of care? Because if you look for the bright line, you'll never find it. It turns out it's really hard to ask a doctor, is this patient now terminal? Do they now have 6 months to live? Is that the magic number somehow? And by the way, how good are we at guessing? Lousy. Turns out we have very poor prognostic certainty about that. And as a result, there are lots of reasons why doctors don't want to lose their patients, and so they'll say, well, no, not yet, right? And families don't want to acknowledge that somebody's died, so we'll say, no, not yet. And patients don't want us, and so we'll say, no, not yet. And so instead of the 6 months of hospice care of the whole person that Medicare will reimburse, for example, right? That's where that magic number 6 months comes from. The average length of stay is something like 11 to 18 days. So the gap between 6 months and 11 to 18, a couple of weeks, is the difference in how difficult it is to acknowledge that boundary between the goals of cure and the goals of palliation. And so the continuity of care model says, then let's not make a bright line. Let's acknowledge that we have mixed goals of care all the time. We're always trying to do more than one thing. So if you think back to the surgery, any surgeons in the room, by the way? I know we have somebody in internal medicine, but surgeons, do they offer anesthesia for their patients? Does the anesthesia actually cure anything? No, but does it make people more comfortable? Sure does. How about, if you get nauseous from the chemotherapy, can we treat the nausea? Yeah. Does treating the nausea cure anything? No. Does it palliate, make people more comfortable? Absolutely. So the only thing that changes is the relative proportion of our care, our total care, that's devoted to one goal or the other. But we always have multiple goals of care. And if there's a single thing that I have more conversations in treatment conferences about than anything else, it's what are the appropriate goals of care at this point in our life. And by the way, appropriateness, the question about what an appropriate death might mean, for many people includes worrying about my family. How are they going to take this? Who's going to take care of them? How are their needs going to be met? And so appropriateness, it might very well be tied to what kind of bereavement support is available for my family. Jerome Bruegel writes a terrific book called The Anatomy of Hope, in which he says he spent his whole illustrious career at Harvard thinking that he was handing out hope cards, like playing poker. He was handing out hope to his patients and then having to take it back at some point. And he said it was only toward the end of his career that he discovered that his patients hope in and for many things other than him and what he can do for them. They hope in religious ideas, in significance, in meaning, in purpose, and value. Albert Camus knew something about this. I'm going to skip ahead. I got lots of advice there for you, but here's what it comes down to. Nobody says it better, I think, than Maury Schwartz in Tuesdays with Maury. He says everybody knows they're going to die, but nobody quite believes it. Because if they did, they'd do things differently, and that's the point of this conversation that I like to have with folks, is to think about how we might do things differently if we're living in the light of our own. So thank you very much for the time yesterday this morning. I'm happy to answer any questions. Think through any of the provocations I've inflicted on you this morning. I have meant in some way to be provocative. Yes, sir.
Well, do you want to say something very briefly about Bishop Anderson House? I mean, is it educational? Is it hands-on treatment? Is it connected with Rush? I got 10 days to live. I go to Bishop Anderson House and say, okay, what are you going to do with me?
Yeah. Bishop Anderson House is a charity of the Episcopal Diocese of Chicago. It is separate and apart from Rush University Medical Center. It's the Episcopal Church's ministry to the whole Illinois Medical District. So they deal with all of the hospitals and health settings in the Illinois Medical District, including Stroger, Hines VA, the University of Illinois, and Rush. I'm the chairman of the department at Rush. Right? I'm the chairman of an academic department as well as the hospital department at Rush. The Reverend Jay Risk, for another month, is the executive director of Bishop Anderson House. I train professional chaplains in the clinical pastoral education program. Bishop Anderson House provides training for lay pastoral care providers who might be based in a parish like this. Right? So they're different charisms, both toward the same goal of supporting the whole human person, and in particular the spiritual needs of patients.
Okay, thank you. I give them money every year, but I always think I don't know really what to do with it.
Oh, it's actually it's remarkable. It's remarkable work, and I was just talking to somebody else. We're tonight having the annual benefit downtown and meeting the new executive director, who's a clinical pastoral education supervisor coming to work with Johns Hopkins, young priest, who will be the new executive director. So it's marvelous work, and we work closely together, but we are distinct. Thank you. Thanks for asking.
It's Jane. Thank you.
Okay, very good.
You're very welcome. Thank you for being with me this morning.